So basically, it's the Isha prayer time here in Pakistan, and I'm sure most of the people will be joining us in a few more minutes. But without any further delay, I would like to welcome Dr. Zeeshan Javaid Hashmi on the online lecture series of PSA Karachi. Thank you so much, Dr. Zeeshan, for joining us today for your lecture on opioid free
Um,
anesthesia.
I
And
think there is some connection problem from my side, or because I cannot hear Dr. Asma.
can you hear me now? Am I clear?
Yeah, yes. Actually, your voice was lost. Is it problem from my side? Can all of you hear me?
Yes, we can hear you, Dr. Zishan.
Okay. So should I start?
Let me introduce you first. Dr. Zeeshan Javed Hashmi is an FCPS in anesthesia from the College of Physicians and Surgeons, Pakistan. He has also done FCI from Fellow College of Anesthetists, Ireland, as well as he's also a European diploma holder from the same institute, and he has also done EDRA, which is the European Diploma in Regional Anesthesia and Acute Pain Management, and he's also a French diploma holder in ultrasound guided regional anesthesia from the University of Montpellier, France. So we would like to welcome Dr. Zeeshan Hashmi, who's currently working in Prince Sultan Military Medical City, Riyadh, Saudi Arabia. Thank you so much, Dr. Zeeshan, and you may start your talk now. Thank you.
Uh, okay, sorry. Thank you. Thank you, Dr. Asma, for giving me a chance to talk in this forum. It's been an honor for me. Actually, since last few years, I was just working on some of the techniques in which we are able to use a multimodal analgesia. Still, this mode of providing anesthesia or this mode of providing analgesia, there are two problems. Number one, not enough studies have been done to make it as a generalized to all over the world. This is one problem with reference to this technique. The other problem is that actually when we are used to one technique with a certain induction agent, certain muscle relaxant, certain specific dose of analgesic, actually it makes your life very very easy, and you are using it, and whatever results, whether they are good or bad, you are used to it. Even your surgical team is used to it, your paramedical staff is used to it. So this is the biggest challenge when you are trying to do something different, and there are a lot of hazards you have to cope with. So the concept of opioid free or opioid sparing anesthesia, there are two more concepts which are actually part and parcel of it. One of them is ERAS protocol, enhanced recovery after surgery, and one of them is actually the multimodal analgesia rather than using one analgesic. So because this is the basis of opioid sparing, because otherwise a number of effects which you are getting with the opioids, they are giving, like, they are time tested, and they are, everyone knows about it. Whatever opioids available in your setup, you are used to it and you are using it without any problem. So this is base of what are the challenges with opioid free anesthesia. Because if you are using it in with someone who does not know about it, maybe there will be problem. This is one thing. The other thing is that the dosage, what medications which we use for opioid free anesthesia, or how you identify it with the different patient group, different surgical group, and how you use it. This is still not generalized. So this is the basic problem. Okay, so we will just see that how we can apply it in our setup and how we can. Okay, so this is the life of anesthetist, running from here, from one part of the hospital to the other part, and actually it's a very challenging job. So opioid-free anesthesia or sparing anesthesia actually make it even more challenging, because you have to um, identify the patient, you have to identify its conditions, and you have, if you are using uh, multiple medications, you have to optimize their dosage in a way that they don't create problem, because a number of medications which we use for opioid free anesthesia, they have some synergistic effect, because additive effect you can cope with, but if there is synergistic effect, which is 1 plus 1 is not equal to 2, 1 plus 1 is more than 2, so that is another problem. Okay. So the things which lead to the use of this opioid free, that one of them was opioid crisis. Okay. So because in Western world, where like all sort of opioids are available, and there was a lot of misuse, because once someone is in have like in, I will say, enjoy, because uh, once upon a time, I had myself experience of taking opioid because I was bitten by scorpion. So that day I received the opioid which is available in Pakistan, and you will be surprised that that opioid is not available in Saudi Arabia, the nalbuphine, which we are using so frequently. So that day when I was in hell of pain, when I received myself this nalbuphine, then I came to know what opioid is, because the satisfaction or the feeling which I enjoyed, I would say enjoyed at that time. Uh, then that give me a just hint of it, that why patient are very comfortable when we are giving a good amount of opioids. But whenever you are using it in that way, there are problems of misuse, there are problems of addiction, because some of the effects of opioids, they are unpredictable, and sometimes you are not able to predict 100% in every patient. Okay. So then this is one of the reason for use of opioid crisis, opioid free anesthesia, or trying to find techniques in which you are avoiding opioids. Then the complications. A number of complications were easily manageable, but some of the complications, like I will give you an example. I'm just trying to give you a background because everyone knows about it, but I'm just giving you in an idea that why it is so important. Like I give you example of a colorectal surgery, in which the main source of post-operative pain will be visceral pain, and it will be a number of things will be associated with the stretch. Okay. So what is happening that you are giving opioids. Opioids are one of the biggest factor for ileus. The ileus will cause more pain. There will be more incidence of postoperative nausea, vomiting, and of because of ileus, as well as the opioid is actually adding more insult to the injury. So this is just one example where opioid will be itself a big cause of the problem. Okay. So if you are avoiding it, then it will be helping a lot. Then this is one of the factors that they started the ERAS protocol for the first time in colorectal surgery. And one of the factor which was very important when they start the ERAS protocol was use of analgesia other than opioids, and minimizing the role of opioids. Okay. So there are a lot of shortcomings and hazards, as I mentioned in my initial introduction. So we just have to see that what is the rationale and how it improves the outcome. So I'm not sure whether this Windows screen is coming on your screen or not, because this screen in which the members are being shown, is it shown to all of you, or it's only coming in my window?
Yes, sir, we can see it.
Okay. Okay. So you can say that before, the old way of anesthesia was mainly based on opioids, and on top of that, they were using some other medications like post-operatively opioid PCA, regional anesthesia, and the last, not used in every patient, was this dexmedetomidine and lidocaine. Okay. So with the use of this opioid-free anesthesia or opioid-sparing technique, this whole arrangement is changed now. Okay. So it will be starting from use of like as multimodal analgesia. I described that multimodal analgesia is the base of opioid free anesthesia, and actually you cannot withdraw these three concepts. So I'm sorry, I will be repeating this word again and again. The use of ERAS, the multimodal analgesia, and opioids-free or opioid-sparing anesthesia have so much interlinking with each other that if you want to be performing this technique, you have to be aware of these things. Okay. So regional anesthesia and use of acetaminophen and NSAIDs. There is a concept of preemptive analgesia. Okay. So preemptive analgesia is the like you are preempting something and you are doing the actions which will reduce the or and you are just anticipating against the problem. Like if there is a forecast of rain, you would like to take the umbrella. So that will be the same thing. So preemptive analgesia starts from the before you give the NCN. So the preemptive analgesia, if you are giving paracetamol, if you are giving NSAIDs, and even if you are using some the gabapentinoids like pregabalin or gabapentin, this is sort of technique by in which you are doing you are trying to blunt the pain pathway, or you are trying to bribe the pain pathway system before actual painful stimulus has been originated. Okay, so this is one of the thing. Then uh, again, like if you are using these of the medications, like some you cannot use these medications in every patient, but you can have a combination of it, and you can identify some patients in which combination will be good. Like magnesium, um, the certain problems with magnesium will be with relation to its toxicity and the arrhythmias which it can produce. Lidocaine is actually is if you are using it in a patient with don't have any liver problem, lidocaine is a very good and very safe way of blunting the stress response. I will just come down further with each of the medication, what is their role. But if you understand this, uh, the concept, then the rest of the discussion will be very easy. Because there are actually, I would like to show something with the by like there are 4 steps. Pardon my handwriting, but I will just try to make it as clear as possible. There are 4 steps: transduction, transmission in pain pathway, okay, modulation, and perception. Okay. So the multimodal anesthesia is technique is actually one in which you are trying to use the medications which are catering the whole of the attacking these 4 steps. Okay. So now, because opioids, they don't have any effect on transduction. Okay. They have some effects on transmission, and actually they are more on modulation and perception. So by use of local anesthetics, okay, if you are like whatever surgery you are doing, if you are just trying to put some local over there, like even giving a local infiltration along, even if you have not given any regional block, even then, if you have just put a bit of local anesthetic along the line of NCN before the surgeon give the NCN, actually you are helping in transduction, and then transmission is also decreased. So this will be decreasing the opioid requirement overall. The stress response will be blunted, and the ultimate result will be better for you. Similarly, as I mentioned about this preemptive analgesia with paracetamol and NSAIDs, because what will be the role of NSAIDs? NSAIDs, what are they doing? Actually, whenever we have pain, usually what we take? We take paracetamol. We take any NSAID, whatever NSAID is available. We don't get opioids straight away. Okay. So this is the same theory over here. And another thing, which is actually as some people don't appreciate, we are using it, but actually it is indirectly helping us in a long way. That is dexamethasone, steroid. Okay. So actually it is also helping in reducing the inflammation. And in majority of surgeries, the somatic component or the nociceptive pain is we are using it for post-operative nausea, vomiting. We are using it for the inflammation of the endotracheal tube, but actually it is helping us as a in a good way for our analgesic regime. Okay, so this is another thing. Then what happens that now transduction, transmission, modulation. So NSAIDs, what they are doing, they are reducing the by giving NSAIDs, we are trying to reduce the inflammatory mediators. So because inflammatory mediators, when they are released, initially there is a primary response and then it is secondary response as well. So they are not only uh, initiating the pain, they are augmenting the pain as well. So that comes in the peripheral modulation. Okay. So by giving NSAIDs, we are covering that pathway. Also, when we are giving paracetamol, it has also opioid sparing effect, and it is also acting on the central nervous system. So it is also because one of the response to the pain is with the reference to hypothalamus. So in the brain, it is acting in the COX-3 receptors. Not exact mechanism is not known, but most probably it is acting over there. So the whole concept of multimodal analgesia and opioid-free anesthesia, you should be thinking about these 4 steps, and then you should be thinking what you can do to get the same effects which we are getting from opioids. So then you will be able to reduce the dose. Then another important thing is the response to pain. Okay. So the response to pain is the thing which you have to control. Like, whenever there is pain, there is sympathetic discharge. Okay. So a number of medications which you are using with reference to opioid-free anesthesia are the medications which are affecting the sympathetic system. Okay. So either, for example, if it is magnesium sulfate, it is also doing the same thing. If it is lidocaine, IV, analgesic dose of lidocaine is between 0.5 to 2 milligram per kg per hour, titrated to the effect according to the sympathetic response. This is one of them. Magnesium sulfate also has the, you can say, membrane stabilizing effect. So what membrane stabilizing effect, that whenever there is more transmission of pain, whenever there is more stimulus, there will be more transmission of pain. So membrane, any medication which has membrane stabilizing effect will also reduce the discharge, which is actually activating the sympathetic system as a result of pain. So magnesium sulfate and lidocaine have this effect. Then comes the dexmedetomidine. Okay, so what I would say that it's my darling medication these days. I am using it, and every day I'm learning more and more about it. Dexmedetomidine actually is coming with the name of Presidex. It is alpha 2 agonist. Okay, and it has central effect, and it has role. So it is decreasing the discharge of sympathetic. It is decreasing the sympathetic discharge by like having presynaptic effect. Okay. So dexmedetomidine is a wonderful medication. It has sedative effect, it has anxiolytic effect, it has analgesic effect, it has sympatholytic effect. Can you people mute yourself? It's a big distraction
Yes,
for
I
me.
would request everyone to kindly mute their mobile phones because your noise is making the speaker as well as the participants uneasy. Kindly mute your mobile phones whenever you join the Zoom meeting.
Okay, thank you. So dexmedetomidine is another medication, as I mentioning, that it has wonderful effect with reference to sympatholysis. So this will be controlling the heart rate, the blood pressure. Okay, because whenever we are trying to see whether the patient has pain or not, usually we are relying on the clinical sign and symptoms, and so this will be a big help in it. Then comes ketamine. Okay, so ketamine is a wonderful medication because people are afraid of it, that it will increase the heart rate, it will increase blood pressure, it will cause sympathetic stimulation. But that is true for if you are using in a high dose. In a low dose, it has mainly effect on thalamus, and it has wonderful effect. Even if you are, for example, you are using it with opioids, even then it is known to have anti hyperalgesic effect. Okay, it has anti-hyperalgesic effect, which is associated with opioids. A number of patients who are receiving opioids, it will be different for different opioids. It is the maximum with remifentanil, because remifentanil infusion, if you are using as an opioid, actually, as soon as you stop it, immediately its effect will be finished and there will be sudden hyper response to the pain. So, but there are different patients who can even developing tachyphylaxis, tachyphylaxis of opioids. So that will be resulting in increased requirement of opioids. Okay. So whenever you are using increased opioids, the other effects will not have tolerance, and there will be more and more respiratory depression, more and more other unwanted side effects. So their analgesic requirement will have tachyphylaxis, but the other effects will not have. So this is the whole. So ketamine in low dose, maybe you can say, but point point 0.2 to point less than 0.5 milligram per kg. It has an excellent analgesic effect. It is using like it is mainly acting on the modulation, and it is giving you an excellent result. So I just wanted to give you an idea, and we will come back to our presentation. Okay. Okay, so a number of things I have told you before. Before the advent of opioids, the goals of general anesthesia were achieved with high dose of hypnotics and hallucination agents, which often caused severe hemodynamic instability. So this was before opioids were originated. So the main advantage of opioids were like they were giving a very balanced anesthesia, better hemodynamic instability. Okay, so that's opioid became popular as they improve the outcome. I'm sorry, outcome after anesthesia and surgery. Moderate to severe pain is reported to occur in 30 to 80% of patients on first post-op day. Opioids are frequently used in the post-operative period due to their analgesic properties. While these drugs reduce nociceptive somatic, visceral, and neuropathic pain, they may also lead to undesirable effects. Okay. Recently, there has been moved towards non-opioid based anesthesia to avoid opioid-related adverse side effects. Many retrospective case reports of single physician experience are available today, but only few, like not very evidence-based RCTs are not done with reference to which agent is being used and how it is. Okay, so currently opioids are mainstay of perioperative pain management, but the use of opioids, even though side effects can result in a pyramid of perioperative side effects. One of them, as I told, these side effects are one of the main reasons that opioids are not included or minimizing ERAS protocol, because the world is going towards ERAS. ERAS is being started. ERAS enhanced recovery after surgery protocol was started with colorectal surgery, then knee replacements, and now they you will find ERAS in almost every surgery. So this is the era of ERAS because it is good for the patient, reduce hospital stay, reduce morbidity using minimum invasive surgery, minimum invasive anesthesia. You are trying to reduce the like expenditure by reducing the hospital stay. So everything is going in favor of the either patient or the hospital. They prevent smooth post-operative recovery and can delay hospital discharge. And the incidence of opioid-related adverse effects in surgical patient or after being treated with opioids were reported as 2.6% in one study and were related to increased duration of admission as well as the healthcare cost. So this is just an idea about the common problems which we face. One of them will be opioid-induced respiratory depression and aggravation of obstructive breathing in OSA. So one of the patients who will be at risk of opioid-related problem will be any patient with coexisting respiratory problem or patients who are like having more chances of respiratory depression as in OSA. Okay. So other problem was post-operative nausea vomiting. So post-operative nausea vomiting following any surgery, especially gastrointestinal surgery, was a big problem. Even you will not be able to discharge the patient if the patient has significant post-operative nausea vomiting. Then again, I explained to you about opioid-induced hyperalgesia, paradoxical response to opioids for the treatment of pain may become more sensitive to certain painful stimuli. Studies have shown that NMDA receptor antagonists inhibit central sedation and prevent acute tolerance to opioids or opioid-induced hyperalgesia. Treatment involves reducing the opioid dosage, tapering them off, or supplementation with NMDA receptor modulators like ketamine. And if you are using it in a patient who are dependent on opioids or who are who are supposed to take it for a longer time, then there will be chances of tolerance and addiction. One important thing is the immune system disorder because they are so associated with changes in immunity, which okay, which will be causing a generation of reoccurrence of even cancer. So this is some of the data with reference to opioid crisis, as I mentioned to you, um, because we don't have local data, so we just have to trust on their data. They are saying that in 2012, the number of deaths related to prescription opioid usage surpassed the number of deaths from suicide or motor vehicle accidents. So this is something very alarming. So they say that without intervention, 1.2 million people in the US will die from opioid overdosage by the end of the decade. So that's why. So this is some more facts about opioid epidemic, killing the people, and the development of addiction. Okay. I just found some of these slides. They are with reference to the data. Okay. This we have discussed already. Okay, so the postoperative use of opioid analgesics is often complicated by the occurrence of PUNV and postoperative ileus, as I told you. Such adverse effects can have negative impact on patient outcomes and increase the burden of postoperative nursing care. Although some current treatment options for these adverse side effects are generally effective, a better option may be to limit their occurrence through the use of alternative postoperative management treatment options. They just have data with reference to a patient with cardiac respiratory disease or OSA or at increased risk of opioid-induced respiratory depression. Okay. Opioid-related, and this is some more studies with reference to opioid-related respiratory and gastrointestinal adverse effects in patients with acute postoperative pain. So you can have acute tolerance. Prolonged exposure to opioids, larger and more frequent doses of opioids are needed over time to render the same level of analgesia, which I explained a few minutes ago. Opioids provide an initial analgesic effect, but the development of acute tolerance can lead to an increased need of analgesics, and opioids may therefore not be particularly effective in controlling postoperative pain. Okay. Opioid paradox: long-term use of opioid can paradoxically induce or worsen pain instead of relieving it. Okay. Response to pain, same thing. I think the repetition, I will just bypass. Okay. In contrast to pain or effect on pain, there was no tolerance to development of the respiratory depressant effect, as I told you. Thus, differential tolerance can develop within matter of hours in animals, and if these data can be translated to humans, patient may, like, they are receiving more opioids, tolerance will be developing, but there is no tolerance to respiratory depressant. So patient will be at risk of. Okay, this was few words about effect on immune system. So you can say the summary of this will be that there is impaired immune system. So this will be more critical with reference to so you can say that opioids will have a bad effect if you are using it in a cancer surgery. The summary of this will be that there is impaired proliferation of macrophages, and there is impaired cytokine production, decreased TNF alpha production. This is all documented. Impaired activation of T cells, impaired B cell response. Okay. Okay, so opioids have been shown to cause immunosuppression and stimulate malignant cells in vitro. So better survival has been demonstrated when no opioids are used intraoperatively and local anesthetics are associated with better cure rates and reduced reoccurrence after cancer surgery. Actually, because majority of the colorectal surgery now is being done laparoscopic assisted. So when they are using laparoscopic assisted, actually the incision pain is not as big problem as with the like open. Okay. So because another point I will just explain to you with reference to use of epidurals. Okay. Because actually you will be surprised that colorectal team even don't like to have epidurals. The reason, again, I told you, as the NCN is not as big as with the laparotomy. This is number one. And number two, whenever we are giving epidurals as an analgesic, there are chances of hypotension. Okay. So as a response to hypotension, either we are using fluid or we are giving vasopressors. I repeat, whenever we are using epidurals for control of pain in colorectal surgery, we are either giving with the response of the medication, if you have given a little higher dose to get there is no chances 100% you can control this. Yes, you can use very small dose, but still there are more chances. So whenever there will be hypotension, either you will be giving more fluid or you will be giving vasopressors. Both of them will be affecting their anastomosis. Okay. If you are giving too much fluid, there will be gut edema, the anastomosis will not be good. And if you are giving vasopressors, again, this will be a problem against and the use of like it will not be good for their anastomosis. So this is another thing against epidurals, and they are using lidocaine IV. IV lidocaine infusion is if very effective to be used in patients undergoing laparoscopic colorectal surgery. Okay. So another problem with reference to opioids is postoperative cognitive dysfunction is a frequent problem in elderly patients following narcotic anesthesia. Of course, other factors you need to take care of other factors as well. The occurrence of POCD seems to be lower with more natural sleep experience from the first postoperative day when opioids are avoided. So now how to use it, the concept of the main, you have to like you want to have a better pain control, sorry, as effective pain control, number one, and you want hemodynamic stability, which is there with the opioids. So if you are using these medication in a cautious way, as I have mentioned already, okay, so paracetamol, ketamine, use of low dose, because the problem, a lot of problem which we face with the dexmedetomidine is with reference to its dose, because the dosage which is being documented is usually the sedation dose in ICU, which is definitely much more than being required in anesthesia when you are using other anesthetic agents. Okay. So you are actually the dose requirement will not be as much as you are using in ICU. So this is a big problem. So a number of points which are mentioned here, I've already explained to you in detail. You are using multiple medications to control or cut down the analgesic response at different steps. And in that way, you are trying to kick out opioid away. Okay. Okay, so target surgery, OSA, bariatric surgery, colorectal surgery, IRAS, CPSP, not our College of Physician Surgeons, Pakistan, chronic post-surgical pain. Though I sometimes this name is used in either direction. Okay, CRPS, cancer-related pain, opioid-dependent patients. Okay, so the medications, as I mentioned already, NSAIDs, acetaminophen, gabapentinoids, dexmedetomidine, ketamine, magnesium, dexamethasone, and local anesthetics being used as IV infusion. Okay. Uh, So, like sedation, dysphoria, delirium, constipation, urinary retention, and postoperative nausea, vomiting, you want to reduce it. And use of OFA promotes rapid recovery, and current enhanced ERAS protocol recommend reducing perioperative opioid usage for an uncomplicated and rapid recovery. Okay. So this is the main thing which I already explained to you. Okay. So lidocaine, analgesic, anti-inflammatory, opioid sparing, and co-anesthesia properties, and they are using it. Only problem will be that if, for example, if the patient liver function is not good, so then they are prone to have accumulation. Otherwise, lidocaine does not have any unwanted effect. If you are using it with the sense, and for example, you have also use a small bit of ketamine, so the requirement of lidocaine will be even reduced. Okay. Ketamine, NMDA receptor antagonist, decrease opioid requirements and the incidence of chronic post-surgical pain. With reference to ketamine, I will also tell you something that if you are using ketamine, you will be surprised that chances of delirium will be reduced. If you are using ketamine in a small dose, the chances of delirium are actually reduced. Okay, this is against our concept that if you have used ketamine, there will be delirium. Actually, small dose use of ketamine with other medications is a prevention against delirium. Magnesium sulfate also is an NMDA receptor antagonist, anti-inflammatory, opioid sparing effect. Again, remember one thing, that magnesium sulfate, you have to monitor its level. You have to make sure patient is passing urine. Otherwise, there will be chances of toxicity. And there will be increased duration of action of the muscle relaxants. So whenever you are using magnesium sulfate, you have to make sure that that's why I have personally, I haven't used magnesium sulfate myself, but there are a lot of people who are using magnesium sulfate. Dexmedetomidine, it's my darling. It has a very, very good effects. It has like a very smooth recovery. Even if you are using it in a like titrated doses rather than giving a fixed preset dose, start with the smaller dose and you can increase it anytime. See the response and try not to use it. If you are using it in a short surgery, try not to give too much dose, because then what will happen? Because remember one thing, with the use of dexmedetomidine, the recovery will be smooth, but the patient may be sleepy. There will be sedative, but there will be no respiratory depression. So you have to identify that there is a difference between respiratory depression and respiratory obstruction. Respiratory obstruction can still occur even with dexmedetomidine, but the chances of respiratory depression will be decreased. So because opioids are associated with respiratory depression, the dexmedetomidine is not associated with respiratory depression. So this is the advantage, but you have to be again using it with care, because if you have given too much dexmedetomidine, the patient may be sleepy and patient may have bradycardia. So and also hypotension. Okay, so you have to use it in a titrated dose. Gabapentinoids, it also has effect on the, like they are being used also as in as a tool for preemptive analgesia. Okay. Role in ARS, opioid minimization is one of the cornerstone of the ARS protocol. I have already explained to you in detail what is the advantage in ARS protocol. Like just few words about ERAS protocol. Everyone knows about it. Maybe it will be covered in some other topic, but this is my like highlight of my practice these days. I love to use this, because if we have a better patient outcome, the result will be overall good for the patient. So ERAS protocol has, like preoperatively, you optimize the patient, you do the risk stratification. Intraoperatively, you have a multidisciplinary team, you discuss what you want, and then you conduct your anesthesia in that way. And you try to have early mobilization, try to avoid the drains or early removal of drains, and early enteral feeding, and very good post-operative pain control. Okay. Mm, I will just, because actually I think we are running out of time. I will try to finish so that we have time for questions. Okay, so these are the challenges: unfamiliarity with the mode of anesthesia, component of drugs, as I mentioned to you, that you have to be familiar of what you are doing. Because if you have used a patient heart rate was 60, you start giving Presidex, and there will be maybe patient will be going in severe bradycardia, and then in worry you have given atropine, the heart rate has jumped to 100. So you don't want it. So I personally, sometimes if I have to use Presidex, what I do, that if the heart rate is jumping between 50 to 60, I just give a push of glycopyrrolate, so that the heart rate is jumping from 50 to 60 to 70 to 80. And then as I start giving Presidex, the heart rate will come down, and but still it will be not in the danger zone. Okay, so that's what I do. But again, I told you that is one of the problems which people, if they don't know about this medication, then they will be having problem. Okay, then another two words about dexmedetomidine is being used in the regional anesthesia as well with spinal. Uh, People are using it, but I read some of the studies that even if you have given spinal and you have given Presidex, even with IV, it will have positive effect on the the spinal as well. So it will overall the patient satisfaction will be increased even if you have not used it in intrathecal. Okay. So in the preceding slides, there will be some studies. I will just quickly go through them, and then last 10 minutes will be for the questions. Opioid-free anesthesia versus opioid inclusive anesthesia for breast cancer. And they found that ketamine, magnesium, clonidine could be more effective than opioid-based analgesia in reducing postoperative pain and PONB. Okay. Feasibility and postoperative opioid sparing effect of opioid-free anesthesia in adult cardiac surgery. So they also tried, I think Dr. Uh, Amin Khwaja can also try this, or they may be using it. Comparison of dexmedetomidine and 3 different doses of midazolam. Because I will tell you something, that as I have started using Presidex, I have reduced the use of midazolam as well, because sometimes it's not needed. Because few patients I gave midazolam and I also gave Presidex, and then recovery was delayed. So then gradually I found, because Presidex, sometime people are using intranasal. So they are giving intranasal, the absorption is very good. And then the patient, we have tried this in the pediatric patients as well. So actually I have stopped using midazolam almost, or reduced it with the dexmedetomidine. Dexmedetomidine versus this is the same thing. Opioid-free anesthesia with a mixture of dexmedetomidine, ketamine, and lidocaine in one syringe for surgery in obese patients. This study was done recently in 2020. In conclusion, opioid-free anesthesia in the form of a mixture of dexmedetomidine, ketamine, lidocaine was used to reduce postoperative opioid consumption in obese patients. Okay. With reference to breast surgery, again, it's the same thing. Opioid-free anesthesia in oncological surgery. I think I'm left with few of the. Just a second. Let me see how many are left. Because I want to do. We can come. Yes, this is important slide. They in one of the surgery. I just took it out from one of the surgery. They are, instead of one patient, they give this one propofol, fentanyl, okay, and lidocaine. And then in one patient, they were using a slightly less dose of propofol with dexmedetomidine, ketamine, lidocaine, toradol is ketorolac. Okay, so they found a better result with opioid free. Okay. Just a second, please. I will come back to it with, because these are the same surgeries in different. Okay. I want to show you something. This is one of the like people who are doing opioid free anesthesia. They have made a society, opioid free anesthesia foundation. They are using it. I want to show actually this thing first before we go. This is, you can say, our old anesthesia technique. Very reliable, very whatever you are doing it, we have time tested. So this is what we have. Opioid free, new, attractive. But if you don't drive carefully, you will have a very bad accident. Okay. So whenever you are trying to do opioid free anesthesia, you have to be, should be quiet and calm. Thank you very much. Because I just bypass a number of studies so that we have enough time for the questions. I know there will be a lot of questions with this. Yes, Dr. Asma.
Thank you so very much, Dr. Zeeshan. Really nice presentation and nice talk and updated one. For all the new participants who have joined us today for the first time, a feedback form will be shared shortly. And once you fill in the feedback form, an e-certificate will be sent to you on your email addresses, which should be valid, which is given initially in the registration form within a week or 2 weeks' time. So kindly fill in the feedback form before we go into the questions and answer sessions, and then we will have comments. So if anyone has any question, they can ask in the chat box. And I would request everyone to kindly participate actively, because this is such a new topic, but also very important topic. And it is one of the topic of debate these days in each and every conference. So, and any questions from the participants?
Asma, first of all, I would like you to ask some questions. because wherever like you can say that even I am facing a lot of resistance in my department about this
Actually,
opioid
you
field.
you are very right. I do have some comments, not the questions, but I do have some comments because we
Oh,
also have been using dexmedetomidine. It's just I'm sharing our experience from a setup
mhm,
which is a tertiary care hospital and where we do the spine surgeries most as the prolonged surgeries. So we do have an experience of using dexmedetomidine both in infusion and initially as a bolus and then as infusions, despite of the fact that and we have also talked about it quite often, and this debate has in fact already closed in on our part, because we have used zero point 0.3 mics per kg per hour of an infusion and have stopped that infusion for at least you can say 1.5 hour to 2 hours before the incision, before the closure of the incision and the extubation of the patient. But still, because that's the spine surgery and the surgeon wants the patient to be awake at the time of extubation, or maybe not at the time of extubation, but within 15 to 20 minutes after extubation, we had so much problem in achieving that extubation criteria. Our patients used to sleep for like 2 hours post extubation, despite of the fact that rest of the parameters would be fine, but they would not move their limb until unless it was 2 hours or something. So we really had trouble in using the dexmedetomidine. Then this is regarding to the prolonged procedures in which we were using the dexmedetomidine. Then we had also used dexmedetomidine in smaller procedures, you can say the orthopedic procedures in which the spinal is being used, and we had given the dexmedetomidine the spinal. In those patients, we encountered severe hypotension and bradycardia. As in, otherwise the patient would be having a normal heart rate of 90 or 89 or even 100, but you despite of using 10 mics of dexmedetomidine in the spinal, patient would go into severe hypotension which would persist for like an hour and a half or two maybe, so far so that we had to use some of the vasopressors to just raise the pressures up, despite of the fact that the patients were not having any comorbids or were not on that verge of the age where that would have caused the extremes of the lowering of blood pressures. So we had encountered both troubles in both kind of patient. Despite, and this is also very true that dexmedetomidine does have prolonged effect of spinal anesthesia when given in combination with bupivacaine. For example, if you are expecting a surgery to be prolonged for more than like 2 hours or something, and you are suspecting that your spinal will wear off, dexmedetomidine is a good drug. But again, you have to be wary of the fact that it can cause hypotension and bradycardia at the same time, in which you have to manage both of the two parameters. So this was one of my observation. But other than that, obviously, when you look at the literature, dexmedetomidine has been used in ERAS, which are mainly the colorectal surgeries. And obviously, when morphine prolonged use and a higher use, it can cause ileus or the decrease in the bowel mobility or the gut motility, or as Dr. Zeeshan has just mentioned, that it also causes respiratory depression that might go well with the higher doses. But yes, it is mostly been mentioned for the ERAS surgeries, but not in spine surgeries. I could find only back when we read it was we could find only one case report where the spine surgery in Korea, they had in KJA they had used I think somewhere one mic per per kg per hour of dexmedetomidine was used along with lignocaine, and they had good results. So I think it also differs with the population to population as well. So
Yeah,
these
Dr.
are just
Shah, I totally agree with what you said, but actually the thing is that what my experience, you will be surprised that I'm not using, for example, I'm using it for lap sleeve gastrectomy, for example. So actually, I don't know what happens, but usually if you are using these paracetamol and NSAID and some lidocaine and some ketamine, actually, believe me, I have sometimes used not more than 10 or maximum 20 mics of Presidex. So this is nothing dose actually. So actually the problem with whatever problem which majority of people face is with reference to the dose they are using. So because there
Right.
are not too much studies done on that aspect, that when you are using Presidex with other medications, you are giving sevoflurane or isoflurane or whatever anesthetic agent, you had given propofol, you had given other medications, and now what will be the role of Presidex? This is the problem. So I think the dose which we give, even if we are saying zero point 0.3, it's a very high dose in my opinion. Whatever my experience, my personal experience it has, the requirement is very low. And if, for example, if you need to give more, as it is someone has written in the chat box, try to use other agents. Like if you want
No,
to
so
have,
what would be the dose? Because the recommended dose is 0.3 to 0.7 mics per kg per hour. That's
yes,
the
Dr. Asma, that
recommended
is
dose.
very, that is the dose which was being used in the ICU, in my opinion.
So what
This
is the
dose was,
lowest? What would be
mm,
your
s-
lowest dose in
my
using?
lowest will be even less than zero point 0.1 microgram per kg, because sometimes you are getting, what is the beauty of Presidex, that sometimes it knocks down the patient even with what I am practically, because this is not, of course, this is not you can say a well documented way, but what I do, I put it in the paracetamol
Right.
initially.
So, Dr. Zishan, actually, we have had problem in titrating it, because that's the only agent which we had been using, especially because we are the only center probably in Pakistan which do the most of the scoliosis cases, and we
Mhm.
do not use inhalational agents
At all.
intraoperatively during,
Yes.
yes, maybe
So
at the
use
time of
propofol.
intubation.
My
Yes,
suggestion,
we
my
no
suggestion
no
will
no
be that you use propofol
no no
and just
you
give a
just
hint of Presidex.
uh, propofol we do use along with dexmedetomidine infusion intraoperatively, and also that with BIS monitoring. So whenever we lower down the doses of the propofol, Presidex, less than zero point 0.3 mics per kg per hour, our BIS reading would go higher to an extent, because neuromuscular monitoring and EMG and EEG is also being done simultaneously at the same time because of the
Okay.
scoliotic patient. So
You have tried to increase the
yes,
dose of
yes,
propofol rather than
we
Presidex.
at 200 mics per kg per minute of propofol use. This is what I'm saying, that we have had used the Presidex in each and every dosage
Um,
which has been
have you tried
recommended.
to just try to add some midazolam and ketamine as well? Because the thing is that Presidex, that's what you are saying. That's majority of people
Actually,
say you are using.
scoliosis patients are different from, rest of the spine surgeries. We cannot use
Mhm.
each and every drug in such kind of patients. But anyways, that's another debate which we can do later on. I think I
Naeem,
should
but I
take.
think you are absolutely right, but I will just add on to it that you are thinking about the things which are affecting the somatosensory or motor work potentials. So I don't think so.
Definitely.
Lidocaine will affect any of them. I am 100% sure. So try to use a combination of lidocaine. Okay, this is one thing. And midazolam, I don't think so. Midazolam does effect on somatosensory over motor. Okay, forget about
No, it
ketamine.
does causes inhibition, I think. It does
Midazolam,
cause it. Yes, both of them, I think.
because I remember anyways, you can check on it, but actually the problem, some of the problems you can minimize. Yeah, Dr. Asma, I think there is
So,
someone who has
so
raised the hand.
yeah, yes, and we also would like to have the feedback, not the feedback, but the comments from some of the chat boxes. So I will start reading them step by step. So Sadaf Hafiz has asked, how do we decide which drug to choose instead of opioid? When do we choose lignocaine infusion, and when do we choose Presidex? So this is for you, Dr. Zishan. Can you please answer
Just a,
that question?
just a second. I missed your question. Can you? I was just trying to maximize the chat box. How can I do?
Okay. So there is Sadaf Hafiz who has asked, how do we decide which drug to choose instead of opioid? When do we choose She's asking about when to choose
Yes. I
lignocaine
found
and
it. I
when
found it.
Precedex.
Yeah.
Yes.
Yeah. Actually, there is no fixed rule. That is what is the challenge in the conduct of opioid-free anesthesia. That because not much of the studies have been done, you can use both of them. There is no problem. Of course, the effect of Precedex is much stronger than lidocaine. Okay.
Okay.
The effect of
Uh,
Precedex is much stronger.
And Ramla
I
has
have
also asked a question. I have a question about cases where we have long cases. Would a lignocaine dose be recommended?
Yes, it
I
is.
think she's
I
asking
can
about
share
the. She's also. I think she's also asking the
dose.
same.
She's
Yeah.
asking about the dose. So actually, the dose is hanging between 0.5 to 2 milligram per kg per hour. Initially, you will be starting at a higher dose, and then you can come down.
Okay, and then there is Abdullah Bilal Muhammad Yaqub. He's asking about different regimes for different surgeries. Are there any different regimes, or the regimes are the similar, plus minus the same for different kind of
Actually,
surgery?
what I have done, that paracetamol and NSAID is in every patient, and very small dose of ketamine, 20 to 25 milligram of ketamine as induction at the time of induction, 20 milligram in adult. Okay. And then usually according to the response, like I just set the heart rate and blood pressure. If maybe I'm achieving it at very low dose, I will not give more, and I'm just titrating. And of course, whenever there is a point, and in any surgery in which there is increased requirement of analgesia, then at that time you have to anticipate. And then another thing is that in the surgeries, other than the Dr. Asma was saying, the scoliosis surgery, that will be a separate entity. But in any other surgery where you can use muscle relaxant, do use liberal amount of muscle relaxant, so that again the overall requirement of anesthesia will be decreased. So this is what I will suggest.
Okay, so there is another question by Dr. Jennifer Rose. She's also one of our continuous participants who attend these lectures. She's asking that OFA is good for RAS and in patients with obstructive sleep apnea, respiratory compromised cancer patients. But if the patient has no comorbidities and healthy young, undergoes painful GI surgery, how do you think about using OFA or opioid for the better pain relief of the patient? I
My
think you have
answer
already
is
given that one. Yeah, you have
yes.
already
I have
given.
already
Yes.
actually the thing is that I will again, the thing is that because I have used personally myself in almost all the surgeries, this regime which I have told you. And I'm because I'm new in the hospital where I'm working, still I am just facing a lot of challenges about it. The people have closed observation on me what I'm doing. But what I have done, that maybe intraoperatively, if the surgery is more than 4 to 6 hours, 4 to 5 hours, I usually repeat another dose of paracetamol and NSAID, and the results are excellent. Actually, when you are getting the parameters, why you cannot use it? Yes, post operatively the problem is that in my opinion, the quality of analgesia, if you have used intraoperatively this Precedex, even the post-operative recovery is very good. But sometimes you need opioids to be given, of course, in the post-operative period, because we are not monitoring the patient directly. In post-operatively period, I just inform the surgeon, and then they control in their normal way, which is, of course, they are using pethidine like green tea. They are using pethidine like a green tea.
Oh. I'm so sorry. I just saw a hand raise, which is by Irene Isono. Irene, can you please unmute yourself and ask the question? I'm so sorry. I just saw your hand raised.
Okay, good evening, Ma. Good afternoon, Irene from Nigeria. So, thank you for the wonderful. Can you hear me?
Yes,
Yes,
yes, we
yes.
can hear you. Thank you for coming
Thank you
online.
so much for the wonderful. You're welcome, ma'am. Thanks for the wonderful presentation. You know, I haven't actually gotten a grasp of all the medications, 10 medications you mentioned, because where I am right now, I haven't been able to use all of them. But for my little practice as a resident, I have been using a multimodal system of analgesia, and it is working perfectly well for me. I haven't come across my patients having all these side effects, these exaggerated side effects of the opioid, like having persistent and nausea and vomiting, going into respiratory depressions and all that. Because what I use down here, most times I do fentanyl, I do pethidine, then I do the pentazocine. Then I give it with the NSAID and then the paracetamol. So and it's been working perfectly well for me. So I don't know, are we trying to eliminate opioid totally? Because I haven't had very
Yeah, yes,
adverse effects
you
from
are.
it. So
Yeah, I'm sorry. I'm sorry. I picked your question. I will try to answer you. Actually, the thing is that maybe
okay,
it's just like opioids came into do the anesthesia practice. Maybe after a few years,
okay,
I can guarantee you that there will be so much good familiarity with these medications that there will be no opioids. And actually, in situations when you, because if you ask me, only best opioid to be used is morphine. Okay, so if you are not using morphine, then you are in Pakistan. We are not getting fentanyl or nalbuphine, or I am 100% sure. I'm not sure about Nigeria. How good is the availability of the medications? But in majority of places, it is highly controlled. Okay, so maybe morphine will be available on the streets, but not in the places where it should be available. So if you are talking about opioid, the best and the effective opioid is morphine, but unfortunately in majority of places we are not getting morphine. So that is the problem. So that's why if you are using this alternative technique, the best way, the advantage is that you are out of this problem. Okay, that's why
I think Dr. Zeeshan has also mentioned about the use of dexmedetomidine or the opioid-free anesthesia. Actually, opioid-free anesthesia does not mean use of dexmedetomidine alone. It means that you can use any of the medications which reduces pain, as because
one
in
combination.
anesthesia it's one of, yeah, it's a combination, and it's one of the entity, one entity of the anesthesia is analgesia. So for analgesia, opioid-free analgesia world is, despite of the fact that the world is moving towards opioid-free analgesia, but obviously the importance of opioids in certain times they will remain there. But having said that, because of the sparsity, because of the crisis, because of the non-availability, we also have to, look at the other options which can be available, which is on the number one is regional anesthesia, wherever you can use it. Regional anesthesia in any form, whether it be spinal, epidural, peripheral nerve blocks, because of the ultrasound um, availability, or even not availability, you can actually do it via the landmark technique. So the nerve block technique is one of the best techniques for the analgesia. Then there comes the other drugs. Yes, the use of dexmedetomidine or not using of dexmedetomidine is entirely a different topic, and actually a topic of debate which me and Dr. Zishan had been doing for the past 10 minutes actually. But there are definitely other modalities for opioid free anesthesia.
all right. Thank you so much, man. I really appreciate it. Thank you. I'll look towards using the other options available. Thank you so much.
Thank you. All have a safe anesthesia and have a good day.
I so
Thank you. Okay, so there are two more questions. What is the dose of magnesium used for this purpose? And another one is, what is your take on the use of dexmedetomidine in C-section? So these are the last two questions, Dr. Zeeshan. I know we are going ahead of time, but can you please
Magnesium
answer these
sulfate,
two?
actually, personally, I have not used myself. I think it should be around 10 milligram per kg, something like that.
Okay, and yes, there is a role of use of dexmedetomidine in C-sections, and I think 5 mics is usually enough for patients in our population, in Pakistani population. I'm not talking about other population, but we personally have used it, and 10 mics does cause a hypotension, so 5 mics is usually enough. Dr. Zishan, that's the last question we are taking, and then I would like to have final remarks from our president, Dr. Shabbir Jamani, who's present here, and then we'll close off the session. So, any comments or suggestions on the use of dexmedetomidine in C sections?
Actually, personally speaking, usually majority of cases they are being done in regional anesthesia. So I have tried to give, as I mentioned to you, like maybe one time I use it in the intrathecal, but then read about it and I found that it is almost equally effective if you are giving as an IV analgesia. So what I have done that I, after giving like spinal, the baby is out, I start put a small dose, 5 to 10 mics in the infusion, and then that's it. So that's what my personal experience, because again, a lot of data is missing in these. They have not used individual, because opioid has become a cornerstone of anesthesia. So there are a lot of energies required to have these things being studied and then find some conclusions, because they are saying that it can create problems. Again, with the Presidex, I again say that whenever you are using Presidex, you should have atropine and glycopyrrolate in your hand. Don't use it without it, because it
All
can
right.
sometimes cause. Yes, thank you.
Thank you so very much, Dr. Zeeshan, for your time and for your input, as well as for your answering of the sessions. I would finally request Dr. Shabbir Jumani, President, Pakistan Society of Anesthesiology, Karachi chapter, to please have a few last words on this topic, and so that we can conclude the session.
Thank you very much, Dr. Asma, for asking me to. And I thank every participant, and especially I thank Dr. Zeeshan for delivering such a nice lecture. And instead of teaching us the pharmacology and these things, he was right on the topic, and he was presenting the updates and recent guidelines of using these drugs, opioids, and it was an opioid-free anesthesia. So, and particularly, I was really enjoying the discussion between Dr. Asma and Dr. Zeeshan. Again, I think these type of activities, academic activities, particularly online lectures, are very useful, in updating our knowledge and increasing our knowledge of anesthesia and related topics. Thank you very much, Dr. Zeeshan, and thank you very much,
Okay,
Dr.
sir.
Asma,
Thank you.
for conducting such a nice lecture.
Thank you, everyone. Thank you, Dr. Zeeshan. And I would request the participants to kindly fill in the feedback form, which is shared in the chat box, so that you can get the e-certificates. The video of this topic will be shared on on the YouTube channel, I think within a month's time. So hopefully we will be able to share it online in a month's time. So thank you very much, and have a good night.
Thank you, Dr. Asma. Assalamu alaikum wa rahmatullah. Bye bye.